I would like to thank BSS for giving us an opportunity to present our research in the gold paper session. Through this paper, we tried to determine if a preoperative TMR MRI change indeed carries a poor postoperative prognosis in patients operated for cervical myelopathy. Cervical myelopathy secondary to old age and degeneration is a very common cause of disability and morbidity, and it is one of the most common presentations in spine clinics. As it is such a major health concern, a number of studies have been done to determine the various prognostic indicators, and a number of studies are also going on at the current time. With the advent of MRI and it having gained popularity and affordability, radiological evaluation for the same has also taken off. However, the most common sequence that has been studied is the T2 sequence, with the T1 imaging being given comparatively lesser attention as compared to the T2 sequence. Combining the two, a number of classification systems have been described, which use either one or a combination of both. Some also use the grading of. In this study, we tried to assess whether T1 changes do indeed matter, and if they're present, whether they translate into a poorer outcome. A retrospective analysis of prospectively collected data was done at Dr. B.M. Central Railways Hospital, Mumbai, which is a tertiary care spine center in Mumbai. All the patients were operated for cervical myelopathy over a duration of 40 months, that is between May 2017 to August 2020, were included in the study, who had a minimum follow-up of at least 1 year. We used two outcome measures. The first one was the modified Japanese Orthopaedic Association score and the visual analogs. We assessed these preoperatively and at postoperative 3 months, 6 months, and 1 year. All the patients who underwent surgery underwent a 3 Tesla MRI with 3 slices, which were assessed and reported by a radiologist who was blinded to the clinical data. Coming to the inclusion and exclusion criteria, we included all the patients who were operated for cervical myelopathy having an age more than 45 years, a minimum follow-up of at least 1 year, and having a complete data set available for analysis. We excluded patients who had no MRI changes on the cervical spine, who had a pre-existing spondyloarthropathy or a history of trauma, tumor, or infection in the cervical spine. We also excluded patients who had a history of previous cervical spine surgery. This flowchart demonstrates our study protocol. We scanned and screened for all the patients who were operated for cervical myelopathy during the time period of 40 months of the study. By applying the inclusion and exclusion criteria, we could find 182 patients which satisfied these criteria. These were further subdivided into two groups. The first one was composed of patients who had only T2 changes in their MRI. These numbered 110. And the second group consisted of patients who had both T1 and T2 changes in their cervical spine MRI. These numbered 72. Coming to the results, this table represents the demographic variables, and as can be seen by the p-values, they were comparable across the two groups. Similarly, the perioperative variables were also comparable across the two groups. The groups are also similar with respect to the approach and the number of levels operated upon. Coming to the MJOS scores, these show a very significant finding. Although the preoperative scores were comparable among the two groups, the post-operative 3 month, 6 month, and 1 year comparison show a significantly poor MJOS score in patients who had both T1 and T2 changes as compared to those who had only T2 changes. However, the post-operative 1 year score was significantly better as compared to the preoperative scores in both the groups. However, the VAS scores are comparable at each point of assessment across the two groups. And the VAS scores at the end of 1 year were significantly better as compared to the preoperative VAS scores in the two groups. Coming to discussion, a number of studies have been published with respect to the T2 and T1 changes. However, a number of studies, for example, Vada et al., Vedantam et al., Chekli et al., and Zhang et al. Have observed that T2 changes indeed carry a very poor prognosis and very poor post-operative prognosis in cases of cervical spondylotic myelopathy. However, not everyone agreed on the same. A study by the team of Michael Fellings et al. And the team from Ganga Hospital said that although T2 alone was not a poor prognostic indicator, a combination of T1 and T2 changes indeed carried a poor prognosis. Now, what could be the reasons for a poor prognosis in patients having T1, and what are the possible implications of the same? To begin with, T1 changes most probably represent irreversible changes that occur in the cord, most probably gliosis, which are irreversible, and thus this provides a better indication to the prognosis after surgery, as cell gliosis cannot be reversed. However, T2 changes are supposed to be caused because of multiple factors like cord edema, obstruction of spinal fluid, degeneration of the gray matter, and myelomalacia. Now, some of these are reversible changes, and thus, in the presence of only T2 changes, these can be reversed. However, it is not always the case. Another way of looking at it could be that these represent a continuum of changes, with T2 changes preceding the T1 changes. As the cord becomes irreversibly damaged, the T1 changes appear, and hence the presence of T2 changes alone might represent an ideal window of intervention to prevent further and permanent deterioration in such patients. We have a few limitations. We are limited by a retrospective nature of our study with a limited power. It is also a single-center study, and we have not used other functional criteria. We have not assessed the post-operative changes in the MRI in the patients, and the grading and classification systems previously described has not been used in our study. To conclude, the presence of T1 changes in the post-operative MRI do indeed represent a poor prognostic indication for the post-operative functional outcome in compared to patients who had only T2 changes. A combination of T1 T2 changes, however, is a much better prognostic indicator than either T1 or T2. In the presence of other adverse indicators, for example, an advanced age, presence of diabetes mellitus, and others, an expected guarded outcome after surgery should be explained to the patient and discussed with him. However, a presence of T1 changes should not be deterrent to proceed to surgery, as the postoperative outcomes after the surgery are much better as compared to the preoperative status of the patient. Thank you.